You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael, Chief Medical Officer of the International Myeloma Foundation and Professor at TGen City of Hope Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Dr. Joseph Mikhael, and welcome to Medscape In Discussion Multiple Myeloma. Today, we're talking about frontline therapy for multiple myeloma. And although sometimes we get very excited about so many of the things that are happening in relapse myeloma with new immunotherapies and CAR T-cell therapy, I have to say there's a lot going on in frontline therapy. We've really had another tidal shift as we're using more and more agents and using them more effectively in the upfront setting. And joining me today to have this discussion is a very close and dear friend of mine who's a professor of medicine and chief of the Plasma Cell Disorder Division at the Levine Cancer Institute, Dr. Pete Voorhees. Welcome, Pete.
Very good to be here. Thank you, Joe.
It's always good to have you with me, my friend. I really appreciate the opportunity to have this discussion with you. This is really a hot topic. As I said, quickly in the introduction, we often kind of get excited about relapse therapies, but there's a lot going on in frontline therapy. And we know that a lot of the people listening today out in the community are trying to decide, how do I treat my patient frontline? Do we still transplant people? What's the best combination? How many drugs do I use? So I'm going to put you on the hot seat a little bit here today because I got 4 big questions for you that relate to frontline therapy. And I want to work through these with you. Before we dive into those, though, I want to tell you a little bit about a patient who I saw in clinic just last week, who kind of embodies a lot of the challenges and yet the gratifying features of what we can do when we treat people in frontline therapy. So this is a gentleman who's 71 years old, and I must say quite fit. He's quite active, and he's recently been diagnosed with myeloma, and he has a lot of questions, which is great. I want to empower patients to be able to read about myeloma. He's been to myeloma.org, and he's been reading about it and trying to understand things that are going on. And he had a whole series of questions for me before he started his treatment. He says, Doc, what is the best treatment? Is it a triplet? Is it a doublet? Do I really need to go to transplant? I got a lot going on in my life now. If I do well, can I delay the transplant, or do I really have to have it right away? And then he even asked me, should I think about trying to get a CAR T earlier than later? So he asked a lot of great questions that now I'm going to defer a little bit to you. But let's start with the first of them, which is maybe the most relevant change in myeloma recently, which is for many years, we went from doublets to triplets, right? We had been giving VD or sometimes RD, so either bortezomib dex or lenalidomide dex, and it was pretty clear the triplets did better, that we saw deeper and more durable responses and longer-term outcomes when we used primarily a VRD strategy, although I'll come back to that later. Sometimes we might use KRD. But have we now gone from triplets to quads? And I know you've led a lot of really important work in this area. In your mind, if someone is planning to go to a transplant, have we really turned that corner? Are we absolutely quads in everybody, or are you still debating between doing triplets or quads?
So I think that the evidence to support quadruplet therapy for newly diagnosed myeloma patients is strong, and I anticipate it's only going to get stronger going forward. So the first study that lended support to the use of quadruplets in frontline therapy was the Cassiopeia trial, which looked at the backbone of bortezomib, thalidomide, and dexamethasone with or without daratumumab as part of induction and post-transplant consolidation for newly diagnosed transplant-eligible myeloma patients. And what that study showed is that for those that were assigned to the quadruplet, by the end of post-transplant consolidation therapy, they were more likely to be in a stringent complete response. Had they received 4 drugs, they were more likely to be MRD negative, and that translated into an improvement in progression-free survival that was statistically significant. Now, the one criticism that has been leveled in the study that's made it a little harder to interpret, and we may talk about this more later, is that there was a second randomization at the time of maintenance therapy where patients either received no maintenance therapy or they received once every 8-week dosing of daratumumab for 2 years. So the question, was, well, how did that influence, progression-free survival in this trial? And thalidomide, while useful in many parts of the world, has been replaced with lenalidomide in the United States, and other parts of the world as well. So we embarked on the Griffin trial, which was a randomized phase 2 study, basically looking at the incorporation of daratumumab into the RVD, or lenalidomide bortezomib dexamethasone backbone, for transplant-eligible myeloma patients. And it was constructed very similarly to Cassiopeia. Patients got induction therapy, they got frontline transplant, they got a couple of cycles of post-transplant consolidation, and then they went on to maintenance therapy with or without daratumumab incorporated into the entirety of the treatment. One of the major differences is that there was no second randomization at the time of maintenance therapy. Everybody got maintenance therapy. So the standard of care arm got lenalidomide maintenance therapy, and then the experimental arm got lenalidomide and daratumumab for the first 2 years, and then patients were encouraged to remain on lenalidomide monotherapy thereafter. And what we showed in that study, just like with Cassiopeia, that rates of stringent complete response were better at the end of consolidation therapy, and rates of MRD negativity were also improved. And we actually updated these data back at ASH in December. And at that time, all of the patients in this trial had completed a minimum of 2 years of maintenance therapy. And by that point, the rates of complete response were approximately 80% in the quad arm versus 60% in the triplet arm. And the rates of MRD negativity were 64% for the quad versus 30% for the triplet. So more than a doubling of MRD negativity at a sensitivity of 10 to the minus 5.
So if we jump in for that for just a second, just because that's such an important area. I mean, I think the field is moving more and more, and this is, going to be an important theme throughout all of our podcasts, that, we see that depth of response, not in every single patient, right, but in general, is a predictor of duration of response. And I think that's what's winning people over. I mean, yeah, you're right. There's the whole challenge of maintenance therapy, but it's kind of an artificial situation. There was no maintenance therapy in one arm. They're giving it once every 8 weeks. I'm not sure it heavily influences right away. Obviously, we've got the big phase 3s ahead to really answer the question. But, has the data you've just presented from Griffin, where daratumumab VRD is superior to VRD alone when incorporated in that strategy of induction and consolidation and maintenance, I mean, has that convinced you now in a patient tomorrow in clinic to give DVRD?
So what I would say is that in the overwhelming majority of randomized studies that have been conducted in multiple myeloma, an improvement in MRD negativity has translated into more durable responses, to your point. The only studies where that hasn't been shown to be the case is where there was a major toxicity signal, that shifted things. So for example, a Bellini trial, for patients that were not selected for 11-14 translocations, for example, there the MRD negative rate was better with the inclusion of venetoclax, but that was offset by increased toxicity for those receiving the triplet versus the doublet of bortezomib dex in the relapse space. But with CD38 antibody trials over and over again, whether it's in the relapsed refractory space or in the frontline space, the incorporation of CD38 antibodies has generally been safe, and uniformly that better MRD negative rate has translated into improved progression-free survival. I will mention too, that the GMMG performed a very similar study that looked at isatuximab with RVD in transplant-eligible myeloma patients, and they presented the primary analysis of that trial back at ASH in December. And what they showed is that with 6 cycles of induction therapy, adding isatuximab into the RVD backbone increased the MRD negative rate. It was approximately 50% after 6 cycles of induction with the quad versus about 25% for those that got the triplet. So, confirming, what we saw in the Griffin trial, you add that CD38 antibody into your IMiD proteasome inhibitor dex triplet, you get a better MRD negative rate. And we are actually starting to see a signal towards improved progression-free survival in the Griffin trial as well. Our hazard ratio was 0.46 in favor of the quadruplet, but the 95% confidence interval was quite large and just crossed the magic 1. So we weren't quite to the level of statistical significance.
I think time will help us see that. I was particularly struck by that GMMG study. That was even before they got transplanted, even before consolidation. We already saw, I think it was 50% versus 35%. I mean, quite a significant improvement in MRD negativity. All right. So you heard it here first, folks, that Pete Voorhees is going on record saying that he thinks these quads are the way of the future. And I think that's way the myeloma community is thinking about it. Well, let's come to question 2 for a minute, which is maybe not as complex, but I think important nonetheless. You referenced several studies actually with Cassiopeia, then the Griffin study, then the GMM-GHD7 study, which used VTD or VRD. But as we know now, we're starting to see quadruplets using KRD, so carfilzomib instead of the bortezomib. Luciano Costa's study of the master trial used DARA KRD with really quite impressive outcomes. And we know that there was the endurance study that interestingly, in a completely different population, not high risk and not going to transplant, they were equivalent with maybe more toxicity from a cardiac standpoint with carfilzomib, a little bit more toxicity from a neuro standpoint with bortezomib. But now thinking as a quadruplist, if there is such a word, what is your thinking going forward, Pete? Are we going to KRD, or is it really whatever you think matches better your patient? A patient who has diabetes and pre-existing neuropathy, you may focus towards KRD, or in other patients, you may focus towards VRD plus the CD38, be it DARA or ESA. What's your thinking there?
Yeah, so I think that the data that have been presented and published thus far with DARA KRD quads are really quite impressive. So you've got the Manhattan trial from Ola Landgren and the Sloan Kettering group, and then you've got the master trial, from Luciano Costa and colleagues, using this quadruplet. And really, what I think is amazing is the rates of MRD negativity that they've seen in these trials, and in particular in the master trial. And I was also struck, as these data were presented and then published, at the rates of MRD negativity at 10 to the minus sixth. There's been no head-to-head comparisons with DARA RVD and DARA KRD, but certainly the depth of response and the quickness in which these patients are achieving MRD negativity is quite impressive. So I think that there's strong non-randomized data right now to support the use of DARA KRD. To your point, the endurance trial would looked at KRD versus RVD in standard risk patients, with newly diagnosed disease that were not going to transplant as part of frontline therapy. And there, there was maybe a slight signal towards improved VGPR and better with KRD over RVD, but progression-free survival was exactly the same. And I think that was a bit of a surprise for a lot of us, because in the Endeavor trial, KD outperformed VD in early relapse patients in a very significant way. And I think the difference here is that, in the endurance trial, RVD and KRD were used for a defined duration of therapy, and then they went on to maintenance treatment, whereas in the Endeavor trial, in the relapse setting, patients could stay on KD or bortezomib dex until disease progression. And I think it's just easier to stay on KD longer because of the neuropathy signal. And I think that that's where the difference is. So I'm not sure, if we were to do a study comparing an RVD-based quad to a KRD-based quad, I don't think that we would see major differences between them. We would see, to your point, differences in the toxicity profile. So you would see more neuropathy with the RVD quad, and you would see more vascular side effects, hypertension, renal signal, pulmonary hypertension, CHF in the KRD-based backbone. So I think you have to just take the patient characteristics and really choose based on side effects more than efficacy.
Yeah, I think that's a really important point. I mean, look, you know what it's like. As a myeloma doctor, what do we want? We want choice, right? We want to be able to tailor it to each patient. And I do think that what you said is very true, that there are differences in profiles. I mean, I think head to head, if you're able to tolerate it, we probably have an advantage with carfilzomib for sure. But I think in this era, especially when you're combining so many agents together, toxicity becomes a really important signal, and we have to look for that. Okay, so it's kind of a bit of a stalemate in some ways. You match it to the patient. I got you. All right, here's controversial question number 3. Not that controversial, but perhaps becoming more controversial, which is there are some of our colleagues who are basically telling their patients, look, we don't need to transplant anymore. We have all these new novel agents. Sometimes we do more damage than good with giving people a big whopping dose of melphalan. This is in the same time as we see something like the Forte trial. So we have a trial that, gave 12 months of KRD versus 8 months of KRD plus a transplant. And even though the response rates were similar and MRD was close, it really looks like the PFS benefited having had a transplant. So transplant ain't dead yet, but what is your approach in the clinic? Just pragmatically, do you still plan to take eligible patients to transplant? Do you have a system where you decide if you can delay it or go immediately to transplant? How is it that you approach it in clinic, Pete?
Well, I've always been impressed by, the attrition data that we see, with each myeloma relapse. And, I'm actually quite surprised to see the numbers of people, who fall out of treatment with first relapse, second relapse, et cetera. And then the other thing that's important to recognize is that, the field is changing so quickly, and the things that are happening in the relapsed refractory space are so transformative. The longer you stay in remission the first time around, the more opportunities you're going to have at the time of your first relapse. So what I typically will tell patients is if you get transplanted as part of frontline therapy, you are giving yourself the best odds of the longest remission that you can have. And by doing so, you have expanded your opportunities for the future at first relapse. And for the 71-year-old patient that we're talking about, transplanting them as part of frontline therapy is probably even more important, because 5 years from now, 6 years from now, getting them through a transplant would be a lot harder than it is at 71 when they're otherwise quite fit.
Yeah, I think that window is really important. That's an excellent point. I think we do have, even from the IFM data, that looked at comparing a bit like the Forte study, VRD 8 cycles versus VRD 5 cycles plus transplant. Some argue because almost 80% of people in the non-transplant arm got one at first relapse, that's almost more of a sequential study. So I think it provides that opportunity. If you have a patient who, really has a good legitimate reason, like this is just not the time I want to get transplanted, doc, especially I think if they're standard risk and their disease under really good control, that patient that's maybe higher risk that you're nervous about, that early relapse, I agree with you. You're going to, knock down more of those clones if you try and give them the transplant. Now, whether or not, if we did this program in a year from now or 2 years from now, my friend, we might be talking about whether or not CAR T replaces transplant.
Right.
We're ready for that discussion. I think that's a little beyond us, but my bottom line here typically is that you're the champ until someone knocks you out, as it were, and transplant is still the champ. Although I think it is reasonable in some people to maybe delay it, especially because you say we don't treat myeloma, we treat people, right? And so if they really feel that this is not the time for them to be transplanted, then delaying it, I don't think is unreasonable.
Yeah, I agree. I mean, the survival signal, both in IFM 2009, in the EMN HOVON trial, we haven't gotten survival data yet from Forte, but the studies thus far, the survival's, the same. So, longer remission, with that frontline transplant, but with a lot of people getting transplanted as part of first relapse, in those trials, the survival is the same. So yes, you're right. There are patients, who can appropriately defer.
Absolutely. Well, that brings us to the fourth and the final question. We've been kind of focusing so far on people that are going to transplant, but at least half of patients say, especially now with the aging of the population, with greater diagnostic techniques, and we're detecting more people with this disease, a lot of people are not going to be eligible. We will address this in a whole discussion with Dr. Ashley Roscoe around geriatric assessment and deciding it. But let's say, Pete, that you've got your patient who, for whatever reason, you have decided that they're not eligible for transplant. You're not going in that direction. We've also seen that triplets are really quite are significantly better than doublets. I don't think we're quite ready for quads in the field, but I know it's being tested. Let's keep it to the triplets for now. What is your preferred triplet? Because we have VRD, which has been a standard of care, but now recently we have great data on DRD versus RD, daratumumab Lendex versus Lendex. Do you have a preferred selection between VRD or DRD in your transplant ineligible patient?
I do. I've generally gravitated towards daratumumab with lenalidomide and dexamethasone for newly diagnosed transplant-ineligible myeloma patients. And largely that has to do with the fact that, the neuropathy signal is far lower with daralendex compared to bortezomib lendex. And it's hard to ignore the progression-free and overall survival data that have been, presented and published, from the Maya trial.
Over 5 years now, right?
Yes, it's going to be beyond 5 years. So at the 5-year mark, about 53% of patients on the triplet arm are still, have not progressed, which is really quite remarkable. And now we're actually seeing the survival improvement. So at the 5-year mark, 66% versus 53% of people alive with the triplet versus the doublet. So these are progression-free and overall survival data that we've never seen before in a newly diagnosed transplant-ineligible patient population. The other thing that I'll point out, and I think, VRD is a terrific regimen as well, but a lot of the patients that were in the SWOG trial were transplant-deferring patients like we just talked about. They weren't necessarily the elderly patients. So 57% of the patients in the SWOG trial were less than 65 years of age. The overwhelming majority of those were likely transplant eligible, but they elected not to get transplanted as part of frontline therapy. Whereas in the Maya trial, the overwhelming majority of people were 65 years of age and older. Only 1% of the patients on that trial were less than 65 years of age. So again, I think that there's a lot of data pointing in favor of daralendex. That said, they've never been compared head-to-head. I know that's something that SWOG is very interested in doing going forward, and I think it'll be incredibly important to see how they perform head-to-head.
Yeah, no, I agree with you. I mean, the average age in SWOG study was 63. The average age in the Maya trial was 73. So, I mean, it's a 10-year difference. It really is apples and oranges. I agree with you. I think in my view, perhaps the only situation where I may start thinking a little bit more about VRD, and I definitely wouldn't give it like SWOG. I try to give it in a way that produces less neuropathy, sub-Q once a week, maybe for 6 months. And then even after 6 months, I switch to every other week, is in the high-risk patient or particularly high-risk patient where we may want the proteasome inhibitor. Well, Pete, thanks so much for all of your input today. This has been a great discussion. We've covered a lot of ground and a lot of studies in a short period of time. So, I would try and summarize what we've said today is that in those patients who are going for transplant, we really do seem to be moving from triplets to quadruplets. The good news is we have choices, whether the CD38 is daratumumab or isatuximab, and even to some degree, whether or not the proteasome inhibitor is bortezomib or carfilzomib. Those are options that can be looked at. But in that transplant-eligible population, we're almost definitely moving towards quadruplets to get a deeper and a more durable response. Transplant still remains a preferred option, but in some patients, especially those who have had a deep response and are lower risk, it's reasonable to defer. And then lastly, in those patients who are not going to transplant, I think we are seeing a shift towards daratumumab, lenalidomide, dexamethasone approach that is more tolerable and likely yields a deeper and more durable response, although there still may be a role for VRD.
Yep.
So thanks again, Pete, for helping us put this together.
And thank you, Joe. Pleasure to be here.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple myeloma.